next 30 minutes, I'll take you across very quickly over the epidemiology and etiology of bladder cancer, the pathology of non-muscle invasive bladder cancer. Then we'll go over the evaluation of a patient with hematuria, reaching a diagnosis of bladder cancer and NMIBC, the transurethral resection, risk stratification of such patients, and followed by a discussion on intravesical therapy. So coming to epidemiology, bladder cancer is the ninth most common cancer that we have. It is usually seen in these decades, the seventh and eighth decade. So most of our patients are old and they have comorbid illnesses. It is much more common in men as compared to women. This is the spectrum of disease, localized, NMIBC, MIBC, and metastatic. These figures usually come from the Western literature. However, all of us who are practicing in India would agree that we see a lot more of advanced bladder cancer in our country. So the metastatic would not be 5%, it would be around 10 to 15%, and even NMIBC would be around 60%, and MIBC coming to 40%. Coming to etiology, so tobacco use is the most common and the most important etiology for bladder cancer. The carcinogens are these three compounds. So when they're excreted in urine, they remain in contact with bladder, they irritate the bladder, and they cause those changes which culminate into bladder cancer. The relative risk for patients who are chronic tobacco users is 2 to 6 compared to the general population who does not use tobacco. And after a 15-year period of smoking cessation, the risk drops down to almost the risk of the general population. Occupational exposure, it has a long latency period, but when you're taking your case, you need to inquire the patient if he or she has had anything to do with working in such industries like rubber, metals, paint, leather, and petroleum. Again, a lot of chemicals, carcinogens, which result in bladder cancer. These are some other etiologies. We have hereditary etiologies. Your patients with hereditary bladder cancer may be younger than those seventh and eighth decades that we saw in the epidemiology. High BMI. So high BMI and obesity has been, a factor for a lot of cancers. Other bladder conditions, some benign bladder conditions like a neurogenic bladder calculi, schistosomiasis, not very common in our country. But these conditions which irritate the bladder lead to squamous cell cancer of the bladder and not usually urothelial cancer. Bladder dystrophy is a congenital condition seen in children. And later on in life, if they do develop bladder cancer, 90% of these cancers are adenocarcinomas and not urothelial cancers again. People in West Bengal, because they have exposure to arsenic in drinking water, this has been postulated as one of the causes. Pioglitazone is an anti-diabetic medication. The FDA recommends that physicians should not use pioglitazone in diabetics who are having risk factors for bladder cancer. And also radiation therapy for cervical and prostate cancer. Radiation therapy anywhere in the body has a side effect of causing secondary cancers. So any radiation therapy to the pelvis, you are at risk for bladder cancer again. So 70% of our bladder cancers are non-muscle invasive bladder cancers. We should not be using the term superficial bladder cancers because even in non-muscle invasive bladder cancers, we can have cancers which have invaded the lamina propria. So these can either be papillary lesions. So papillary lesions can be of three types. Papillary urothelial neoplasms of low molecular potential, which we call as spun lumps, or they can be of low grade or of high grade. Then we can also have flat lesions, which are carcinoma in situ. They can either be primary, so carcinoma in situ existing with a papillary lesion in the first TURBT that you've done for the patient. They can be secondary, that is, you did a TURBT for a papillary lesion and in follow-up the patient develops CIS, or they can be concurrent. So NMIBC can be TIS, that is carcinoma in situ. It can be TA, that it has still not invaded the lamina propria. It can be T1, where it has invaded the lamina propria. This figure, tells you about the genetic alterations. I do not expect you to, learn all this. What I wanted to realize is we have low grade bladder cancer here and we have high grade bladder cancer in the middle. So what we need to realize is the mutations which are responsible for low grade bladder cancer and for high grade bladder cancer are completely different. So there are two dichotomous cancers that develop in a patient. A low grade bladder cancer may progress or change into a high grade bladder cancer. But to begin with, a low grade bladder cancer has had different genetic alterations in the patient compared to one who has a high grade bladder cancer. So in your patient who has hematuria in your case presentation, the most important complaint that the patient will have is painless hematuria. Gross hematuria, if you have, there is 20% chance that you may pick up bladder cancer in this patient. Patients who have irritative symptoms